Our link will have only 8. We are waiting for your call, Rishi.
Yes, sir. Just give me a call when we want to go live so that we'll go live.
1 live. Over to you, sir.
Okay, we are live, sir.
Yeah. Good evening, and once again, thank you very much for all the encouragement you have been giving us. It is your encouragement that is allowing us to continue to do this program. In fact, there are a lot of meetings and a lot of examinations which came up in the last week or so. So for nearly 10 days, we are off the program. Now we have come back. Now today, a very important topic we are taken for discussion, which is testicular malignancy. 100% you will get a case of testicular tumor. If it is physically available, it will be either a long case or a short case for you. If it is not available, you will definitely have this in your afternoon session. One of the specimens in every medical. Manohar Guda has joined us from the Department of Urology, Guntur, and Dr. Arjun, who is head of Department of Urology, Sapthagiri. Taking the first session with Dr. Manohar sir. That will be on the. We have another candidate for you, who is Dr. Venkat from Apollo Hospitals, Chennai. And he'll be taking the component of investigations as well as hyochirectomy with Dr. Arjun. And for our presentation, we have, as usual, Mohammed Salman with us. So if you are all ready, Mohammed Salman, can we go ahead? Manohar sir and Rishan, over to you.
Okay, thank you.
Shall we start, sir?
Please go ahead.
Yes. So a 30-year-old male came with the chief complaints of swelling of right testis for 1.5 months. He also had a history of low backache for 1.5 months. Otherwise, he did not have any history of burning menstruation, no history of loss of weight appetite. There was no trauma, no history of fever, LUTS, or vomiting. Past history, he is not a diabetic, hypertensive, or any other comorbidity. He has no history of previous surgeries. Family history, no history of significant family history. History wise over, sir.
Yeah. Can you stop at this stage? And
Yes.
we can now take Rishan. And Rishan, you can discuss with Manohar sir regarding the history. 30-year-old gentleman has come with complaints of testicular pain on one side only.
Yes, sir.
So, you have told the chief complaints. Can you explain in detail the history of presenting complaint, like for the swelling, onset, duration, and pain characteristics? I don't
Sir,
think about that history of present complaint. You can elaborate more.
sir, this is a 30 years male patient who presented to the clinic with the chief complaints of mainly swelling of his right testicle, and the duration of the swelling is around 1.5 months before he presented. And yes, sir. And associated with the swelling, he doesn't give any history of pain, but only he gives a history of low backache of the same duration. He also doesn't give any urinary complaints like any dysuria or any Lutz syndrome, and there is no constitutional symptoms like any weight loss, appetite, anorexia associated with the complaints of swelling of the testes. And he also doesn't have any past history of any trauma or any history of fever. And his family history and other personal history were also insignificant.
So, can't you elaborate more on the history? You are telling on right side is total swelling. You mean it's an insidious onset? It is increasing size. Okay, it's painless. You think it's painless. Okay.
Yes, sir. Yes,
and so, you think the testicular swelling and backache are simultaneous? Do you expect a testicular swelling associated with back pain simultaneously, or any gap will be there? What will be the mode?
Sir, it might be insidious. There should be a gap, sir. It is always not expected to be at the same time, sir.
Okay. Can you elaborate about the testicular swelling more? Is it on self-examination he found it, or he has went to the urologist for what purpose he has went? How is
Sir,
it
he
diagnosed?
Sir, he noticed the swelling to be insidious onset, and he noticed the swelling while taking bath one day. And initially, he did not give much attention to the swelling, but once he noticed that it was slightly increasing in size, that was when he consulted the urologist for opinion, sir.
It's a painless swelling.
It was
When
a
you
painless
expect
swelling.
a painful swelling in the test.
Sorry, sir.
When you expect a pain in the testis, it is
Sir,
painless. You
yes,
expect
sir.
a
It is a,
testicular mass to be painless. Okay.
yes, sir.
When you expect pain in a mass,
Sir, it can be a painful swelling if it is a testicular torsion or if it is any kind of infective etiology like epididymoarchitis, then the patient might present with painful testicular swelling.
if it is testicular, if you suspect testicular malignancy, when it will be painful?
Sir, when there might be intratumoral hemorrhage, in those cases, the patient might
The
present
rapid
with
expansion of the testis,
rapid expansion. Yes,
infarction, you can expect a pain.
yes, sir.
So, can you tell anything about history? So, you expect a testicular, what is his age?
Sir, 30 years.
So, you expect a testicular tumors, incidence of testicular tumors around?
Yes, sir. The incidence of testicular tumor is mostly around the age of 20 to 40 years, and it might vary depending on the whether it is a seminomatous or non-seminomatous.
Type of tumor type. So,
Yes.
seminomas will present later or non-seminomas?
Sir, seminomas will present later. Non-seminomatous present earlier, sir.
So, you expect you are having a testicular tumor which
Yes,
is
sir.
increasing in size since 1.5 months and is not associated with pain. So, do you want to elaborate on any other symptoms, any other causative factors of this increase in size at this age group? Have you asked about any other history or directly telling about no history, no history? What
So
is the
whether
cause? You should
whether there's
ask
any
most important cause of testicular neoplasm will be most important risk factor.
sir, any family history, whether there is history of
Personal history, we are not
also
elaborating.
any personal history also, sir.
Have you asked
Also,
about the childhood, any personal history?
testis was
child, yes, sir. Also any history of undescended testis if the patient
Yes.
has any history.
Have you asked? Have you asked?
Yes, sir. Yes, sir.
Have you asked? He has no
Yes,
answer.
sir. No, sir.
What are the other risk factors for
Sir,
malignancy, testicular malignancy?
sir, classically there are five.
Apart from hypothyroidism,
Sir, there are classically 5 defined risk factors. First is a racial factor, which is white races are more prone than the black races. The cryptorchidism, the personal history of testicular cancer, the family history of testicular cancer, and any history of germ cell neoplasia in situ.
any history of
If the patient has any history of GCNI, like the intratubular.
neoplasms, how can you tell where germs of neoplasm in situ or intratesticular neo, ITGCN, how can you diagnose it? When it is classically diagnosed?
Sir, mainly in the prepubertal.
It is diagnosed incidentally when you
Yes, sir.
investigate for infertility. When you investigate,
Yes, sir. For infective.
then only you can. Classically, they will describe intertubular germs of neoplasm. Okay.
Yes, sir.
So,
Yes.
have you inquired about any other history? Want to ask about any other history? History of trauma?
Yes, sir. I asked, sir. There was no history of trauma, sir.
History of trauma. Is it associated with malignancy?
So it can be incidental findings, sir.
Any other history of sexual transmitted diseases? Have you inquired?
He's unmarried, sir. So and also he doesn't give any history of any.
So what is most
Also,
important? Sexually transmitted infection that can be associated with the tumors. You have asked
yes, sir.
sexual history.
He doesn't give any history of any
So
high risk behavior.
For commonly, HIV is associated with the seminoma. Okay, HIV
Yes,
with
sir.
patients in have seminoma. So what are other testicular differential diagnoses you expect?
Sir, it can be it's a painless swelling, so it can be any infective etiology also, like any epididymoarchitis. Sometimes
One is epididymoarchitis, other is
it might
there's a
be
differential diagnosis of testicular tumors. One is epididymoarchitis, other is trauma.
it can
Third,
trauma, sir.
it is more can be torsion.
Torsion of the testis, sir.
So you have inquired about any other history. You want to inquire about any other history?
whether the patient has any constitutional symptoms
You
like
talked about backache. So what do you suspect if he's having backache?
sir, mostly in cases of patients with testicular swellings with backache, it might be because of the lymphadenopathy, which might cause because of expanding of the lymph node mass, which might cause the backache. Or sometimes it can be insidious also. It might not be related.
So have you inquired about if it is retroperitoneal lymphadenopathy, how it presents? Any symptoms will be there?
Sir, the patient might present with swelling in the inguinal region, sir.
Inguinal region.
And
Retroperitoneal lymph nodes not felt in inguinal region.
retroperitoneal lymph nodes, the patient will have stomach. Sometimes it may have stomach
discomfort.
Abdominal discomfort. Yes, sir.
So you think it is metastatic symptom?
Sir, retroperitoneal lymph node always is not metastatic symptom. So it is a regional lymph nodal basin for the testicular tumor, sir. If it is within the regional lymph nodes.
So any other metastatic symptoms you have to ask? Any other?
Sir, if the patient has any breathing shortness of breath, if the patient has
where it can migrate, metastasis.
So the lymph nodes, the
primary
chest.
site is the retroperitoneal lymph nodes. Okay,
Yes,
that is the primary landing site. Apart from where they can go.
Chest, sir, it can go to the chest, sir.
If the chest, what are the symptoms you want to ask?
Sir, if the patient has any shortness of breath and breathing difficulty.
Shortness of breath, any a cough.
Cough or hemoptysis.
Dyspnea, okay.
Yes,
and any other sites you want to inquire? There are symptoms you should have. If you think backache is a metastatic symptom, if you should ask other metastatic symptoms also, to which organs they will metastasize. So one is, so most common site being retroperitoneal lymph nodes, you can present with abdominal lump or abdominal discomfort or GA. Other is you are telling about lung and any other sites.
Sir, it sometimes can also metastasize to the brain if it is a.
So brain, what are the symptoms you would like to ask?
So the patient might have history of seizure. The patient might have history of episodes of loss of consciousness.
Plastic encephalopathy is also explained, where eye vision will be blurred, eye vision there.
Blooding of vision, sir.
Limb involvement can be there. So you told two sides, lung and brain. Any other sides are there you want to ask?
Sir, sometimes it might also metastasize to the supraclavicular nodes, sir.
So you can have a neck swelling.
Yes,
so
sir.
You can have a neck swelling. Very good. Any other sides you want to? So basically, seminomas will, which is the preferred route for migration of seminomas?
Lymphatic, sir.
Yes, very good. Lymphatic. So retroperitoneal lymph nodes with the primary lymph nodes, and then from there they will go.
Then it will go to the other side, sir, to the lymphatic channel, to the thoracic duct.
To the cisterna chyli, to thoracic duct, to the supracardiac. There is a supracardiac lymph node, most common left arm. That is one. So lymphatic spread. That is seminomas. Non-seminomas most common presented, especially some other carcinoma. Preferred route is?
Sir, especially for choriocarcinoma, it is a hematogenous most preferred, sir.
So hematogenous lung and other sides?
Brain can also be spread to the hematogenous route.
Next, lung or liver.
Sorry,
liver.
Sir? Liver, yes, sir.
Metastasis in the liver can present with?
So it might present with jaundice, episode of jaundice.
So in that history. So these are the lung, liver, brain. Okay.
Yes, sir.
Spinal cord. Your spinal cord can be backache in present. So these are some other sites you should inquire also. Metastatic symptoms also you should inquire. So you have inquired about other symptoms. But you have inquired about lower urinary tract symptoms.
Sir, if the patient is, yes, sir. Yes, sir.
Yeah, we told.
The patient, yes, sir. I have mentioned, sir. The patient doesn't have any history of dysuria or any history of lower urinary tract symptoms, sir.
Any other symptoms you have to inquire? So if you think it's a tumor, you should inquire also about any other. Excuse me?
Sir, sorry, sir.
Yeah, loss.
Loss of testicle.
Loss of
testicular sensation.
And any other pedal edema can also be there because of IVC compression.
Because of the IVC compression.
Can also be there. So these are the symptoms you should inquire. So about swelling also, if you can elaborate more on which side is more common. When you, on which side you expect it is to be more common? Testicular cancer.
Right
More
side, sir.
common?
Right
Yes,
side, sir.
very good, wonderful. Why? As undescended testis is more common on right side.
In the right side, yes, sir.
So on clinical examination, any other swellings you want to differentiate?
We can ask about whether it
Sir,
increases on
about
size.
Yes, yes,
Whether,
please.
whether swelling increases on size, whether swelling increases on
So other swellings, other testicular and inguinal
Sir, I
swellings.
also want to see the contralateral testis, sir.
Yeah, wonderful. Okay, but it's not, you are in the examination only. You are
Yes,
not
sir.
to clinical examination. You are just taking history only.
I'll
So
ask the patient,
percentage
sir.
of contralateral testis getting affected? Bilateral, what is the incidence?
2%.
Sir, 2%, 2%, sir.
2%. So usually they will be metachronous tumors. Okay,
Metachronous.
not simultaneous, metachronous with 0.5%.
Yes,
So
sir.
you want to inquire any other thing? Any other?
Also, sir, if the patient has any other swelling in any part of the body, like if the patient has any swelling in the neck, or to just rule out the metastatic spread, sir.
Okay, if any has surgery, if he has inguinal lymphadenopathy.
Yes, sir. Any scrotal or inguinal surgery.
Why? Why? How it is relevant?
Because sometimes, sir, this might represent some with the burned out primary tumors.
Lymphatic drainage path.
Lymphatic drainage, yes, sir.
So, inguinal lymphadenopathy can be there after scrotal inguinal. Okay.
Yes.
So, these are the history I have asked. So, history of swelling history and metastatic symptoms history should ask. Okay.
Yes, sir.
So, now you summarize the history.
Sir, we have a 30 years gentleman who presented with an insidious onset right-sided scrotal swelling of a duration of 1.5 months, which was associated with a low back pain, and there was no metastatic symptom, and it was not associated with urinary complaints, and with no significant past or family history.
So, family history means, do you know if family history is there, what would be the risk? If father is affected, what will be the risk? If brother is affected, what will be the risk? Increased risk.
So the risk increases by 2 to 4-fold times if the first degree relative is affected with the testicular malignancy, sir.
Okay. Brother?
Yes,
okay.
Sir.
So there is no significant family history. So,
no, sir.
Okay. Then?
Sir, this was a history part, sir. Now with this history, I would like to come to the examination of the patient, sir.
Okay. So personal history, you don't want to ask anything?
The personal history I have already taken, sir. If the patient has any history of any, whether the patient is married or not, if he has any history of high risk behavior.
Okay.
Just, yes, sir.
That's the thing. What is the effect of children? Is having children or not? Does it have impact any bearing on his presenting complaint? So, you know testicular dysgenesis syndrome?
Yes, sir.
What is it? So, patient presents with undescended testes.
Yes, sir.
And subfertility. So, patients with one of the more risk factors is subfertility is also considered as a risk factors. Okay.
Okay.
So, okay. Proceed. So now you are presented with a swelling testis of insidious origin. Okay. Insidious onset of 1.5 months duration. So, personal history. Any other things in the personal history you asked apart from STDs? Any other thing you want to mention?
So, if the patient is married or not, and whether if he has any children or not, also if the patient has any high risk behavior like sex, having any, all those I have asked, sir.
Then you are going into examination. Okay.
Yes, sir.
So, what are the, sir? Am I finished, sir? Chengalvarayan, sir. Sir, can I continue or Dr. Arjun will take over, sir?
I think, sir. Please continue, sir. I think we can do it together. Please go ahead, sir.
Okay, sir. Mute. Then mute.
What specific examination do you want to do in this patient?
Sir, I'd like to, sir, like I'd like to start my local examination with inspection, sir, to see to corroborate with the history that the patient is saying of the swelling, and also I'd like to on after inspection of the local area, that is the scrotum, the genitals, and then I'd like
What
to
do you want to
palpate,
inspect in the scrotum?
sir, whether to see if there is any visible swelling or not, or if there is any apparent skin changes over the swelling. Also, if there is any signs of inflammation over the skin of the overlying skin, sir.
Would like to see whether swelling is arrested. Where is the swelling? Is it arresting on the scrotum or inguinal scrotal region?
Venous scrotal extension.
Extension
Yes,
of the swelling, yes, sir.
whether the test is separately palpable or not, whether it is arresting the testis or
Just
paratestic.
palpation. We are on inspection.
Okay, sir. How is the skin? Any discharges there from the skin? Any
Why do you want to know if there's discharge from the skin?
can go to epidermolysis if the patient has, or if it can be TB also, but it involves the
Patients have you seen with discharge from the skin?
Sometimes
From the
tuberculosis of the testis might.
Tuberculosis, yes.
Yes, sir.
Think of that.
Yes, sir.
Anything
How is
else?
the opposite?
Opposite
How is the
side.
opposite testis?
What if the opposite does not have rugosities?
Means it's not well developed. It may be still undescended testis also, sir.
Yeah. So what are the chances that the other side is undescended and this side there is a tumor?
Venkat, the question is
Chances
very
of other
clear.
sides having.
Correct.
Okay.
And now that Venkat has taken over the discussion, Rishan, can you take a small break? I know Venkat has come to save you. You take a small break. As a final year, Venkat has come to save you. Yes, Venkat and Arjun. You
So
can
we've
discuss
started
them
with
on-
examinations, sir. He is on inspection.
Yeah.
So after, apart from inspection, as it's seen on the screen, this is abdominal. We are looking at local inspection. So, yeah.
On
So
local
this is your
inspection.
inspectory findings. Right hemiscrotum, the skin rugosity is lost. Multiple sebaceous cysts are there. He's made it more complicated. So swelling of the size 6 into 4 centimeters on inspection, occupying the right scrotum, no scars, sinuses, or dilated veins. You want to next? You want to go ahead?
Would like to confirm the inspectory findings with the palpation, sir.
Yeah, great. Go ahead. Palpation. Can you tell me some things that you want to see in particular for scrotal swelling?
Would like to check the get about the swelling.
First sign, yes.
And the cough impulse is there or not.
Okay.
To rule out varicocele, Valsalva Manohar like to ask to do. The consistent.
Why do you think? Go ahead.
Just to rule out, sir, to rule out inguinal scrotal swelling, to rule out varicocele, to like to know the consistency of the swelling, and if it's cystic, would like to do a translucency test.
First thing, what will you do when you touch the testis? What do you feel for?
Consistency is a firm to her. What is the
Check
consistency?
if the patient has pain or no.
Tenderness, sir.
Sorry?
If the patient has if the testicle swelling is tender or not, sir.
Correct.
The patient has, yes, sir.
So, what difference between a tender swelling and a painful swelling? Why? What would you expect in a carcinoma testis?
It will be a painless swelling.
Why is there no pain in a testicular swelling?
Now it's a compress between the tumor mass and the tunica albuginea.
What is the classical description that they'll tell about a carcinoma? Charlie is asking about that, I think. So sensation, do you think anything about sensation?
Correct. Testicular sensation is lost.
Lost, sir.
Yes, sir.
Sir expects that answer, I believe.
Anything else? What are the classical findings in a testicular tumor?
What is the consistency of the swelling, sir? Whether it is firm or hard in consistency, whether it is.
If it is either firm or hard, you cannot rule out a testicular tumor.
Whether separate testis is palpable separately or not.
Second point. Yes. If it is palpable separately. Next.
So generally, these are hard, painless swellings. The testicular malignancies are generally hard, painless swellings, and these are discrete, separate swellings.
Can you separate the swelling from the testis? Can you feel the swelling separately from the testis?
No, sir.
No, sir.
Okay. So finding of a non-tender, hard, non-fluctuant swelling. The left hemiscrotum and testis are normal. Inguinal region is normal.
Okay, sir.
Next, what do you want to do?
Would like to summarize and would like to further evaluate this patient with an ultrasound of the scrotum.
You want to check the
Sir, I'd like to do the abdominal examination.
abdominal examination. Yes.
Already, they put up.
You don't want to examine the penis?
Yes.
Any relationship is there?
Why?
To rule out if there is any evidence of sexually transmitted disease.
Okay. I told you just now, any hypospadias, anything in
Hypospadias, yes, sir.
In Klinefelter syndrome, what you see, the testis. What do you expect in Klinefelter syndrome? Will it increase the risk of testicular malignancy?
Yes, sir. Klinefelter syndrome is a risk factor for testicular malignancy.
What do you expect in the test?
It is a testicular dysgenesis, sir.
Ectopy will be there. Ectopic
Yes, sir.
the risk factors for the man.
Yes, sir.
Proceed. Sorry, sir, for interruption.
Please, sir, you're more than welcome. I think that helps. So, the examination is done. Can you summarize and give a differential diagnosis?
30-year-old male presenting with right scrotal swelling for last 1.5 months, along with back pain for last 1.5 months, with no significant past history, no significant surgical history, no significant family history. General examinations are unremarkable except for the 6 centimeter right firm to hard testicular mass. So my first differential diagnosis, this would be a malignancy of testis.
So that's your first. Any second and third?
No, sir. Of course, maybe 10 hydrocele I can give, sir.
No.
Even the trans.
Why are you thinking hydrocele? Did you do a trans-elimination test?
There will be 10 side, maybe a 10 hydrocele, sir. So, or if hydrocele has component as pyocele, hematocele, even the transformation might be negative. Just to add up the differential diagnosis.
So you're mentioning about only testis. You don't want to mention about spermatic cord. Huh? Have you mentioned about spermatic cord? Have you mentioned? I have not found.
Spermatic cord was not mentioned.
Spermatic cord. The cord structures are able to particular difference. When
Yes, I
you
get about the.
No, sir is asking cord and cord structures when you palpate. Is it important to feel them?
Yes, sir.
Why? Which conditions?
Sometimes that when we see adenoma of these patients might the condition of this adenoma of the spermatic cord, they also present with this swelling, sir. So it is important to see if there is any swelling in the spermatic cord.
tumors are there. Extragonal tumors are there. They can present with this scrotal swelling.
Yes, sir.
Rishin and Venkat,
Yes, sir.
sorry for interference, sir. Let us assume that it is a testicular tumor for all practical purposes because you have a painless testicular swelling. Although we have differential diagnosis of hematocele or old age filarial scrotum, which we used to see, not seen nowadays at all in many of the places. There is an importance which Arjun sir is asking. Did you look for the spermatic cord? Is it important to feel for the spermatic cord in these patients?
I think
And what
sir
is the
is
importance?
sir is being a nice internal. He's giving clues. So what else? What else do you feel for?
Forget about varicocele, epidermolysis,
Sir,
and
the
all.
epididymis, we have to feel the epididymis, the vas, to see if there is any swelling in there is a varicocele also, if there is any
Forget
swelling.
about varicocele, epidermolysis, everything. Let us assume it's a testicular malignancy for all practical purposes. What is that you want to feel in the spermatic cord? Or otherwise, what is the sign of VAS?
What is sign of VAS?
It's a very famous exam question. You will definitely face this question in the exam. VAS is never involved in a testicular tumor. So VAS will be filled separately. But the spermatic cord veins can be involved. As the tumor progresses, you remember you have to put a soft clamp, right? So that you don't want these to go through the veins. The spermatic cord veins can be involved. They can be filled, but VAS is usually filled separately. So that is the reason why we insist on palpating the spermatic cord or looking for the spermatic cord. Yeah, please sir, go ahead, sir. Please, sorry. Salman's spermatic cord was normal in this patient clinically.
Yes, sir.
Yeah, Salman says the spermatic cord is normal in these patients. Yeah.
So go ahead, Venkat sir.
Go ahead, go ahead.
Would like to have an ultrasound of scrotum along with tumor markers alpha fetoprotein, beta HCG. Okay, sir.
Wait. Tumor markers. What are the tumor markers you wanted?
Alpha fetoprotein, beta HCG, LDH, sir, lactate dehydrogenase.
Are there any other tumor markers?
So placental
Placental
alkaline
alkaline
phosphatase.
What is it? What is it useful in?
seminoma,
Indicative
sir.
of?
Seminoma, sir. Placental
Seminoma,
alkaline
sir.
phosphatase in seminoma.
Anything else? Can you give me one more?
CD117, CD30.
No, those are not histopathological.
Okay, sir.
CA? CA
Not
also
sure, sir.
is a will. Okay. Well, you have the ultrasound scrotum.
Ultrasound shows.
When you ask for an ultrasound scrotum, what do you ask for? Ask the radiologist in particular. You just want a soft tissue scan?
With the Dopplers.
Okay.
So ultrasound shows.
What you will see in normal testis and what you will see in testicular mass. See, especially you can differentiate seminomas and choriocarcinoma or something. What will be seen in seminoma? What will be the echo texture?
Homogeneous in case of seminoma, sir.
Homogeneous, you call it
Hypocrite
normal.
mass homogeneous in case of seminoma. Whereas in case of non-seminal germ cell tumor, it was hypocrite and heterogeneous.
It will be a solid sheet of cells in there. Okay. In case of rectoma, you can feel sometimes an necrosis hemorrhage can be seen. Okay.
Okay.
With altered echo.
So apart from the report that you asked for a scrotal ultrasound. What are the things that you want the radiologist to look for? Mass is evident. Vascularity
Yes,
is
sir.
evident. Anything else you want to look for? As Sir said, one, the nature of the mass, whether it is homogeneous or heterogeneous. Anything else?
Any other
Whether it
structures?
involves spermatic cord or epididymitis.
Okay, those are all normal. So here there's a hypercoagulation, right testis, internal vascularity, bilateral spermatic cord, normal. Epididymis is normal. So right side, there is a tumor. You're happy with this?
Yes, sir.
You don't want to know about the other testis?
They mentioned normal, no, sir. Opposite.
Sorry?
They are mentioned in this report, sir. It's
Yeah,
normal,
so
normal.
I agree. See, what in particular do you want to see in the opposite testis?
Whether microcalcifications are or not.
Yeah.
Oh.
So I have two microcalcifications on the opposite testis. How would you interpret that?
Grade, not significant. You have to grade it, the microcalcifications are grade 1, grade 2, grade 3.
How do you grade it?
Less than 5 is grade 1. Grade 2 is 5 to 10. Grade 3 is 10 to 20, sir.
I think 5 more than that. But any radiological sign for microcalcification?
Snowstorm appearance.
Snowstorm appearance. So what is a snowstorm appearance? Can you give me certain criteria which classify it as snowstorm appearance?
Less
So I
than 2
have
mm.
around grade 2 microcalcifications. Can I say it is snowstorm?
Not sure, sir. Less than 2 mm, that means multiple.
Less than 2 mm, correct. One. Second, there should not be acoustic shadowing.
Okay, sir.
Third, it used to be diffused throughout the testis.
Okay, sir.
Yeah, and the number of calcifications also has to be dense. At
Okay, sir.
least 5 to 10 on every plane that they are seeing.
Okay, sir.
Okay. The other testis is normal. Done. Next, you wanted
Tumor markers.
tumor markers. So only 3 markers. Tumor markers, can you put up? So you have to tell me, these are numbers. Can you tell me in correlation with, read the tumor markers and tell me in correlation with the normal range.
Alpha fetoprotein is 209.
So normal range?
Around 10, sir.
Around it doesn't come.
Less than 10.
So 0 to 8.5, sir.
Yes. Okay. Agreed.
Uh,
Then this, so it is elevated.
is elevated, sir. Beta
Yes.
is 678.
Yes.
So normal will be around less than 20 to 30.
Okay. The next one, that is also elevated. Next.
Yes. LDH is 592.
Yes. Normal range.
So
Not
0 to
sure.
248 international unit per liter is a normal, sir.
Great. So all 3 are elevated. Is it a good thing or a bad thing? What is
Mostly
LDH? What is elevated LDH indicative of? Is LDH
tumor
important
burden.
to us? Does
Tumor
it tell
burden.
me there is a, is it a tumor burden? Correct. But it is not specific to the
For any
testis.
tumors.
Yeah.
Yes, sir. Just in case burden of the tumor.
Correct.
Since all tumor markers are elevated, most likely are dealing with the, and since he's 30 years old, most likely are dealing with non-seminomatous germ cell tumors, sir.
Yeah, but I'll say AFP is elevated to 209. It is not a testicular tumor. So am I justified in saying that?
Not
Other
able to get
causes
you.
of AFP elevation. Sir is asking other causes of
Question
AFP.
is, yeah, what are the other reasons for
elevation.
AFP elevation?
Hepatocellular carcinoma.
Yes, wonderful.
Oh,
This is an easy one. Can you tell me others?
smokers.
At least 5. No. Smoker is not the condition.
Okay. Surrounding structures.
Correct. Yeah. Okay, let's go to the easier one. Beta HCG. Can you tell me other reasons beta HCG is elevated?
Not sure, sir.
Marijuana. You just talked about smoking. Here it comes.
Now, beta HCG means there must be an alpha HCG.
Yes, sir. Beta alpha unit, beta subunit.
Okay. So, can you tell me what the others are elevated in? Okay, I won't trouble you.
The TSH and so
Yes.
alpha subunit shares with the TSH and the prolactin. So
Yeah.
TSH and LH. TSH and LH.
LH, yes,
They share the same as alpha subunit.
Yeah.
it shares the same alpha subunit.
So LDH is also elevated. So tumor burden. So does it indicate anything? That means a testicular tumor is large. Is that what you mean?
It is a disease burden, sir.
So what does this indicate? If I say beta HCG of 5,000,
Yes, sir.
is there something that you have to think of?
So basically, in the
Yes.
recent TNM classification, it is classified as S1, S2, S3, depending on these elevations of this
Tumor
level, sir.
marker elevation. Okay.
Tumor marker elevations, sir.
Yes. Yes. What is S1?
S1 is, sir, when LDH is less than 1.5 times the normal, when AFP less than 1000, and when the beta IC is less than 5000. That is S1, sir.
So here you think?
This falls in the range of S1, sir.
Yes, sir.
Okay, these are your tumor markers. Is tumor markers also
sir.
indicative of additional investigations?
Sir, sorry, sir.
Tumor markers. Would you base tumor markers to do additional investigations?
Next investigations, what you want
Yes,
to
if
do?
beta HCG is so much
Sir, if beta HCG,
If beta HCG is very high,
high,
then
you can
you
ask for
can go
imaging
for
of
brain imaging, sir.
correct. Okay. I think could one of you tell the reason why?
hematogenous but high risk of hemorrhage, brain metastasis.
Okay. Okay. So these are your serum markers. Any other investigation you want?
If possible, I would like to also have the CECT thorax abdomen pelvis at this stage, sir.
Why?
Would like to do a staging even before oculectomy, sir, if it's possible. I would not like to delay the oculectomy for this investigation, but if it is can be done without delay, I would like to do it before oculectomy, sir.
Don't want to stage?
Yes, sir. That's what, sir. For staging only.
CECT.
CECT scan, abdomen and pelvis and chest. You want to do chest X-ray or CEC?
CT, sir.
And chest.
CT
When
chest
you will do
abdomen.
CT scan chest? Any indications are there?
What are the indications of chest CT?
When the patient is symptomatic or
Okay.
X-ray chest conclusive, or when the patient has high tumor burden.
Seminomatous, would you want to do a CT chest? Or all patients with non-seminomatous, you would want to do a CT chest?
Yes, sir.
Yeah. Okay. Any other indication post surgery which would you want to do a CT chest?
To look for the if there is any retroperitoneal mass.
Chest.
Chest.
So I've done an orchidectomy.
Yes, sir.
And I tell the resident, do a CT chest. After a few weeks after orchidectomy. If there is an increase in the tumor markers post orchidectomy, if there's no fall, that is also an indication for CT chest.
Yes,
Okay.
sir.
It's a metastatic disease.
Metastatic disease. How long would you wait for the tumor markers to fall?
4 to 5 half-life, sir.
4 to 5 hours.
How many days does that come up? Can you tell me the half-lives? We didn't get the half-lives. Alpha
LDH 24 hours, so like for 5 for 6 days. Beta HCG 24 to 36 hours, so 7 to 8 days. Alpha fetoprotein 5 to 7 days, so like to wait around 35 days.
That was
how much it will take? How long it will take the tumor markers to normalize after orchidectomy?
5 to 5 half-lives, 4 to
4
5
to 5
half-life.
Weeks or months? When you would like to repeat the tumor markers after orchidectomy?
At 1 month, sir, 35 days.
At 6 weeks.
4 weeks. 4 weeks.
4 to 6 weeks.
Yes.
You come prepared with that answer. Okay. Next. So these are your tumor markers. What would you want to? What would your diagnosis be at this point? Would you be able to histopathologically classify this?
Non-seminomatous germ cell tumors at this point of time.
Yeah. Can you give a justification as to why?
Because alpha fetoprotein is raised, beta HCG is raised. Alpha fetoprotein is raised in case of yolk sac tumor, or beta HCG is raised in case of cholelcarcinoma. Whereas in seminomatous tumor markers are mostly raised, except in 15% of cases of seminoma or beta HCG can be borderlinely raised.
Okay. What would you want to do for this case now? You want any other
Would like to
investigations? You have an abdomen, you have a CT chest, you have markers, and you have a soft tissue scan.
Would like to do a routine-based investigations for preoperative assessment, CBC, LFT, coagulation profile, creatinine.
Are you expecting any abnormalities in this patient? Nothing.
Nothing, sir.
Yeah. So all reports are normal. So what do you want to do?
would like to explain the patient with empathy and sympathy the disease which he is suffering from. I want to explain them the need for high inguinal radical orchidectomy. Would explain the risk complications associated with that.
He's a
And
30-year-old male. The minute you say that, he says, no, sir, removing the testis, no, I've read online, you do a biopsy.
I'll tell them
Do you want to do a
biopsy.
biopsy?
No, sir. It will
Why
cause a
not?
scrotal violation, alteration of lymphatic drainage,
Okay.
high chance of local recurrence.
Indication for biopsy?
No indication, sir.
No indication. And then he says, no, I read something called a partial orchidectomy.
I'll tell them in your case, your ultrasound, all your tumor markers, or
indications of partial orchidectomy. Sorry, last I think. Indications of partial orchidectomy.
Sir, if it is a bilateral tumor or
bilateral tumor.
or tumor in a solitary testis, sir.
Okay, that's a first indication. Next.
Yes, sir. Less than 3 centimeter, involving less than 30% of the tumor volume.
30%.
Testis volume. 30% of the testicular volume.
Okay. But what is the problem in doing a partial orchidectomy?
Sir, the adjacent testicular parenchyma has this germ cell neoplasia in situ. So
Correct.
sometimes there is high chance of recurrence.
So after orchidectomy, do you have to do after partial orchidectomy, you have to do something?
Sir, a frozen section.
You have to take a biopsy from the. After sending frozen section, you have to take the normal tissue.
It comes negative.
Biopsy, sir. Check for ITGCN.
It comes negative.
If ITGCN, keep under surveillance, sir.
Correct. If it comes positive,
radiotherapy, sir. 20 to 40 day radiotherapy can be given.
Sorry, could you repeat that?
Radiotherapy, sir. 20 day radiotherapy to the remaining testes.
Anything you want to do before doing that?
Sir, contralateral testis will also have to be evaluated, sir, because in 5 to 9% there is GCNIs in the contralateral testis as well.
Yeah, I'll give radiotherapy to that testis also.
Sir, before that, I'd like to see the fertility status of the patient.
Sperm preservation. Sorry.
Sperm count preservation, sir.
What is the other problem with partial orchidectomy? Once you do a partial orchidectomy, do you perceive any other problem that can happen? So there will be an alteration in the testis barrier.
Testis barrier.
Yeah, so they become more immunogenic.
Okay, sir.
So what procedure? So both are ruled out. You explained to him both cannot be done. So what do you want to do?
Pineal orchidectomy, sir.
So what does it mean?
Means after either general anesthesia, spinal anesthesia, in supine position, we'll give an inguinal incision to send above the inguinal ligament.
Is it the same thing as a radical orchidectomy?
We'll go up to the deep inguinal ring, sir. We like to involve the spermatic cord. Spermatic cord will be taken up to the deep inguinal ring, sir.
Okay, I clamp it, I cut it off. Is there anything that you do differently in an orchidectomy for CA testis and orchidectomy for anything different you do in this condition? You open the inguinal canal, you are doing a high inguinal orchidectomy.
Yes, sir.
What are the specific words that you have to use to clamp?
Soft clamp to the testis.
Yeah. What is Shivasu's maneuver?
In case of Chevasu maneuver, where the ultrasound is indeterminate or tumor marker is negative, so I put a soft clamp on the spermatic cord. I open the tunica albuginea vertically. I'll send a tumor along with normal tissue for the frozen section. I would like to also take a biopsy from the adjacent normal parenchyma to rule out interstitial tubular germ cell neoplasia. If frozen section is negative, I will close the testis to lay.
Okay. What if the tumor is stuck to the scrotal skin, infiltrating.
T4 staging, sir.
T4,
Sorry?
sir.
Yeah, so how will you do a high inguinal orchidectomy there?
I'll remove along with the scrotal skin, sir.
How much of the scrotal skin? Both sides?
Oh, only on the side it involves.
Yeah, but what is the lymphatic plane there? Okay, so you've done a high inguinal orchidectomy.
Yes.
Manohar sir?
Yes, sir. So you want to do after radical orchidectomy, you expect here you are expecting which kind of tumor?
Non-seminomatous germ cell tumor.
Non-seminomatous. So what will be the differences between non-seminomatous and seminomatous tumors? Any staging difference is there?
T staging difference is that in case of seminoma, T1 can be further subclassified into T1A, T1B based on a size less than 3 centimeter, more than 3 centimeter.
Yes, yes.
Other all same, so T1, T2.
In pulmonary mets, there is a difference in staging. Okay. Between seminoma and non-seminoma. What will be the staging? What will be the T2 and T3? Can you tell? What is the staging? T1, T2, T3?
T1 tumors confined to the testis without lymphovascular invasion.
T1, yeah.
T2 tumor confined to the testis epidermis with either lymphovascular invasion or tumor involves epidermis or tumor involves a hilar soft tissue. T3 tumor involves a spermatic cord and T4 tumor involves a scrotum.
That is same for both. So in the pulmonary mets, there is a difference between semina and non-semina, I think. Okay. Non-semina,
Yes, sir.
non-pulmonary mets.
The prognostic group, the good prognostic, the intermediate, and the poor prognostic group changes, sir.
Okay. So here you expect which stage, you don't know. In histology, they have taken the biopsy report. Is there available or not? Biopsy report is available or not? They have done orchidectomy or not? They have not done.
Not yet, sir.
High inguinal orchiectomy done for this patient, sir. Biopsy report is actually awaited. And
Sir.
as Manohar sir is asking, Rishan, what is the likely biopsy report for this patient?
Sir, it might be a mixed type of non-seminomatous germ cell tumor, non-seminomatous germ cell tumors, sir.
No, fine. It is a non-seminomatous germ cell tumor because alpha fetoprotein is raised. It cannot
Yes,
be
sir.
seminomatous, and beta HCG above 500 cannot be seminomatous. So we are likely dealing with a non-seminomatous germ cell tumor. What kind
Yes,
of
sir.
non-seminomatous germ cell tumor can produce both alpha fetoprotein and HCG? What
Embryonal can produce, sir, both embryonal
Correct,
type.
correct. Embryonal cell carcinoma, mixed germ
Yes,
cell tumors are the common one that can produce alpha protein
both.
as well as HCG. And this is
Yes, sir.
also the age group for that. 20 to 30 is also the age group for that. Is embryonal cell carcinoma a nice tumor or a bad tumor?
Sorry, sir.
Bad
Is it a good tumor or a bad tumor for you?
Bad one.
aggressive tumor.
Why bad tumor for you?
Has totipotent capacity to
Totipotent cancer.
Totipotent is for teratomas. Yeah.
aggressive tumor also. Can transform into other malignancy also.
It will metastasize early. Why? Sir is asking. What are the characteristic feature histopathological
My
finding?
bandwidth, my bandwidth is a little low, so you could have missed me talking. So it can de-differentiate into a teratoma and keep quiet, or suddenly it can become aggressive and produce multiple metastases. Now, what we are worried about these metastases when they happen in the brain as well as the lung is these metastases.
Hello.
Hello?
Hello.
Yes, sir.
Yes, sir. Chengalvarayan, sir.
Patients, yeah, is bleeding from the metastasis to the brain and as well as the lungs. That is where embryonal cell carcinoma is a very tough carcinoma to deal with. Yeah. So the biopsy report we are waiting, sir. Most likely it will be embryonal cell carcinoma or a mixed germ cell tumor. In that lines, how to proceed further, Manohar sir will guide you. Yes.
So,
Would like
what is the various options for non-seminal germ cell tumor? Stage 1 to stage 4. Stage 1, non-seminal germ cell tumor. What you would like to do?
Stage 1 would like to stratify the patient, sir. Whether
Stratification.
lymphovascular invasion present or not.
Yes,
So
very
in
good.
this case, in case embryonal carcinoma component is there. So if either embryonal carcinoma component is there or lymphovascular invasion is there, my first advice would be to go for single cycle of chemotherapy, sir. BEP, bleomycin etoposide cisplatin.
Is there any load for surveillance in stage 1 non-seminal germ cell tumor?
Yes, sir. If the patient has no lymphovascular invasion, if the patient has no embryo component, the first option would be to go for surveillance.
Then next will be any
The
role
patient,
for primary RP-LND.
yes, sir.
When you will do RP-LND, usually in the tumors, testicular tumors.
After chemotherapy, if the mass is persistent,
Yes. After chemotherapy, if the mass is persistent,
Persistent.
residual mass, you would go
5
to
to
like
9 mm, sir.
RP-LND. So
Yes, sir.
any role for primary RP-LND in non-seminal germ cell tumors? Does it have any prognosis?
Yes, sir. In case of stage 1, the patient, in case of the patient has lymphovascular invasion or the patient is not willing for chemotherapy, we can go for primary RP dissection, sir. Or the patient has no lymphovascular invasion or no embryo component, but the patient is not willing for surveillance. Then in those cases, we can advise them chemotherapy or primary RP.
For stage 2, what you would like to do?
In case of stage 2, further subclassify into stage 2A, 2B, sir. In case of stage 2A, would like to know the tumor marker status. If tumor marker is elevated, would like to give the induction chemotherapy, 3 cycles of bleomycin, etoposide, and cisplatin, sir. And if tumor marker is normal,
Only
in this
BEP
patient,
cycle is there or any other cycle is there?
other cycle regimens are vinblastine, ifosfamide, paclitaxel, VIP, VEP, TIP, sir. 4 regimens are there, sir.
Okay.
So in case of stage 2A, if tumor marker is negative, I would like to give the patients of follow-up after 6 to 8 weeks, sir. At follow-up, if the mass is reducing in size, I will keep them under follow-up. If mass is increasing, then I'll again repeat the tumor markers. If now tumor marker is increasing, I will do a induction chemotherapy followed by lymph node dissection, sir. If tumor marker is normal, I will go ahead with retroperitoneal lymph node dissection.
So
This is
for
for 2 years, sir.
RP-LND, what are the templates you know? So for right-sided tumors and left-sided tumors, do you know any? Can you tell us any templates are there?
Yeah, superiorly the renal hilum, renal vein,
Basically, right testis
laterally,
or left testis drainage. Any difference is there?
Yes, sir.
yes,
Sir, there
right interitocaval nodes, left parietic nodes.
Crossover, where in which side
right
of the
to left,
testis
sir.
there will be
Right
crossover?
to left. Right to left,
Right
sir.
to left, there will be crossover or lymphatic. So what is the primary landing site for right testis?
Interaortic cable, sir.
And
And the
paracaval.
paraortic and the paracable.
Paracaval. So left testis?
Is a paracable, sir.
Parietic, sir.
Aortic. So paraortic and preortic is a landing
Incorrect.
site. So templates will be based on that. Okay. So RP, LND you have done. After residual mass for chemotherapy or post chemotherapy residual mass you would like to do. So for stage 3 you would like to do what you would like to do?
Primary chemotherapy.
Stage 3, I like to stratify the patient based on international collaboration group.
Okay.
Good risk, intermediate risk, poor risk, sir.
Sir.
Would like to know where is the site of the tumor, that is testicular tumor or retroperitoneal or lymph node or from the mediastinal tumor. Would like to know any non-pulmonary visceral mets is there or not. Would like to know the tumor marker status S1, S2, S3.
Yeah.
If it's a case of S1 and testicular tumor or retroperitoneal tumor, when there is no non-pulmonary visceral mets, it's a case of good risk, good prognosis. If it's a case of S2 with no non-pulmonary metastasis, it's a case of intermediate. And if it's a case of S3 with non-pulmonary visceral mets present and mediastinal mass, it's a case of poor risk tumor, sir. So based on this, I will give the chemotherapy, sir. For
which subgroup is chemo resistant?
Sir?
Which type of non-seminal germ cell tumor is chemo resistant?
Teratoma.
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 Teratoma. What is growing teratoma syndrome?
Sir, sometimes
After
teratomas.
chemotherapy also, the mass increases with increasing tumor markers, sir.
After chemotherapy,
After chemotherapy, mass increases in size with rise in tumor markers.
tumor markers will rise or they will normal? They will rise.
Rise, increase in.
So what you will do?
I'll have to surgery, the excision.
So for teratoma, surgical excision is the treatment modality. Okay. Sir, Arjun sir.
Before excision, would you want to confirm something? Would you want to do a biopsy?
Biopsy can be done, sir, to confirm the teratoma nature.
What would you look on the biopsy?
Multiple mesotome, endodome, all components of the tissue, sir.
It shows
Which are
teratoma. Anything else which you want to see on the biopsy?
Not sure, sir.
Okay. So, well, you have a tumor with rising tumor markers.
Okay, sir.
What is your plan of surgery for here?
Stage, sir, like we have already given a chemotherapy or not? Oh, tumor markers, right?
The patient that you were discussing, stage 3, no?
Okay, sir. So if it's a stage 3, you would like to visit him based on international collaboration group. Like to give a chemotherapy first, sir.
Yes.
Bleomycin, etoposide, cisplatin. 3 cycles if it's for good and intermediate, and 4 cycles for.
Yeah, stage 4, stage 3, 4 cycles of BEP.
Yes, sir.
Or
Yes,
EP, you know about EP?
Extra 1 cycle, sir. 4 cycles. With 3 cycles. If the patient has any lung issues, the patient is not fit for bleomycin, we'll increase EP 4 cycles of etoposide and platinum, sir.
What are the side effects of bleomycin?
Pneumothorax, lung
pulmonary fibrosis. Yes, sir.
Pulmonary fibrosis.
Pulmonary fibrosis.
Arjun sir. What will be the follow-up? How long you will do the follow-up? Minimum of?
5 years, sir.
Minimum 5 years.
5 years.
What are the in the follow-up? What you will do?
Sir,
clinical examination of the patient. As the patient.
Which investigation you would like to do in the follow-up? An interval.
Main thing is to check the opposite scrotum, sir. Opposite testis, how is it? And tumor markers and imaging, sir.
Which imaging?
So chest X-ray and abdominopelvic CT scan, sir.
There are certain intervals are there. In first month, first year, how will you do? Second year, intervals are there for tumor markers. And CECT is any role or not? Any role of PET CT scan?
No, sir.
No, sir. Only in case of seminoma, specific.
Sir, Arjun sir.
Sir. Changal sir is not able to join us because of some issues.
Yes.
We'll continue without sir for a while.
Yes, sir.
What if, do these tumors occur in the pediatric age group also?
Yes, sir. Yolk sac tumor is most common.
So how would you manage in a pediatric tumor? Would there be any difference?
Pediatric age, there's very high chance of being a benign tumor. So would like to have a partial occlucectomy as my first preference, sir.
Correct. That is the one thing. Anything else? So how would you treat if it comes off as a yolk sac tumor?
If other testis is normal, you have to complete occluctomy on this side.
Okay.
The patient has normal testis on the other side, would like to do a completion high occluctomy on this side, sir.
Could you tell me briefly the guidelines for the, now we have discussed non-seminomatous. Can you briefly discuss the seminomatous?
Seminoma can be further subclassified into stage 1, stage 2, stage 3, sir.
Yeah.
So stage 1 tumor, I would like to further risk classification with the tumor size and involvement of Veti testis. If tumor is less than 4 centimeter and there's no involvement of Veti testis, I would like to keep under surveillance, sir, with tumor markers evaluation, X-ray chest and CT abdomen, sir. If the size is more than 4 centimeter or if the involvement of Veti testis is there, I would like to give a single dose of carboplatin, sir. This is for stage 1 seminoma.
Mm.
And for stage 2 seminoma, can be further subclassified into stage 2A and 2B, sir.
Yeah, what is the disadvantage of giving carboplatin? What are the toxicities?
One is reduces nephrotoxicity, has effect on the kidney, reduces GFR, audiometric hearing loss, peripheral neuropathy.
Okay. How
But
do you know how to calculate the dose for carboplatin?
area under curve 7, I guess. Don't exactly, sir.
Say GF7 minus GFR plus 25 milligrams, sir.
Correct. So 7 into GFR plus 25.
Plus 25 milligrams.
Yeah. Okay. Any role of radiotherapy here?
Yes, I can. Dog-leg radiation 20 Gauge can be given, sir. Stage 2A to B.
Okay. How do you give? Do you know the schedule of the radiotherapy?
15 Gauge into two sessions, sir.
Without any break.
25 to 35 grain, 15 to 20 daily fractions. That is the recommended. Sir.
Yeah. Okay. What chemotherapy would be given for an alternative option to stage 2?
Which is preferred? Do you prefer radiotherapy or chemotherapy, given the choice?
Seminoma first radiotherapy, sir. Or if tumor marker is elevated, I like to give an induction chemotherapy first.
So what options are there for chemotherapy for stage 2?
One is bleomycin, etoposide, platinum, sir. Other one is etoposide, platinum, ifosfamide. Third one is vinblastine, ifosfamide, and platinum. Fourth one is paclitaxel, ifosfamide, and platinum, sir.
What are the side effects of cisplatin?
Same, nephrotoxicity, audiotoxicity, peripheral neuropathy.
What problem if a patient has, would you not give a cisplatin based drug?
So we have to see if the patient is cisplatin
Would
eligible
like
or not.
So what is cisplatin eligibility?
Would
So
like
the
to check on the
patient has
Galsky
to-
criteria. One is performance status less than 1. Other one is EGFR more than 60. Then grade 2 less than grade 2 hearing loss, less than grade 2 peripheral neuropathy, and NHOA New York heart classification less than 3, sir.
So you've given chemotherapy to a patient. How will you follow up? And this
You have to
patient,
assess.
which was a stage 2 patient, he's come to a stage of chemotherapy. You've given chemotherapy. How would you follow up?
It follow with the tumor markers and CT scan of the abdomen and pelvis, sir.
Okay, in stage 3, would
Same,
you
sir.
again
Tumor markers and
stratify
CT.
this? Would there be a necessity to stratify this patient again?
Whether the patient is responding to chemotherapy or not.
So how do you assess that?
Whether tumor markers are becoming normal, whether mass is reducing in size.
So there are 4 classifications for this response. One is a complete response.
Okay.
One is a partial response with marker positive. One is a partial response with marker negative, and one is progressive disease, sir.
Okay. So if post chemotherapy, we assess by doing a CT scan and we do find a residual mass. So how would you go about it?
We would like to see if it's a case of seminoma or non-seminoma, sir.
How will you find out?
No, the initial pathology will tell us whether it's seminoma or non-seminoma, sir.
Yes, we are discussing stage seminomatous.
Okay, so in case of seminoma, we'll do a CT scan and we'll see if the mass is less than 3 centimeter. We won't intervene, sir. If the mass is more than 3 centimeter,
Won't
we'll do PET
intervene
scan.
as in, would you do surveillance?
Follow. Yeah, we'll keep under
Follow.
surveillance and
Correct.
follow.
It is called surveillance. So more than 3
Okay.
centimeters.
We'll do a PET scans, FDG PET scan, sir.
Okay. When would you do
And
this PET scan?
after
Immediately
some
after
8
chemotherapy?
after 2 months, 8 weeks.
Yeah. Anything after 6 weeks.
Okay, sir.
So if it is positive,
So then we'll do retrobundal lymph node dissection, sir. And even if vertebral lymph node dissection, if it is tumor biopsy comes as necrosis, nothing to do. If biopsy comes as any tumor is there, then we would again like to give 2 cycles of chemotherapy, sir. Bleomycin bladder.
yeah, that's true. What if there's a relapse? Biopsy shows, the PET is positive. What if there's a relapse of the seminomatous tissue?
Relapse comes further subclassified early relapse, late relapse, sir.
Okay.
If it's early relapse, I would like to give an alternate chemotherapy. If it's late relapse, I would like to do a biopsy, considering it may be a teratoma, sir. First.
Correct. Changal sir is back with us.
Yeah, somehow managed to come back.
Yes.
Yes, and we are so happy, Arjun, in spite of the fact that the exams are going on, we still have 85 people on the other side listening to this program. And both you and Manohar sir are taking in a very nice way. And also listening. Yeah, please
Nice
go.
to hear, sir. So I think there are some questions.
There are a few questions that have come up in the chat. I think the most of the component of this particular case has been discussed. There are a few questions that have come up in the chat. One question, Manohar sir would like to take. Why is a testicular sensation absent in a CA testis? The answer for that is it depending on how much of normal tissue has been replaced by the malignancy. If the malignancy is large and replaced all the normal tissue, obviously the nerve tissue of the testis is also destroyed. That is the main reason why there is an absence of testicular sensation. But it is not always present in all cases. If it is a small tumor, testicular sensation can still be present. The other question that has come up is how long should we wait for the tumor markers to come down? I think that has been discussed.
4
Rishan, can
weeks.
you just say again?
4 weeks. 1
4
month,
weeks.
sir.
Yeah, each tumor marker has its own off life. So you have to
Yes,
wait
sir.
for 4 to 5 off life. So roughly around 4 weeks, most of the tumor markers would go down. And should this S staging be done before surgery or after surgery? Before orchiectomy or after orchiectomy? That is another question.
After surgery.
After surgery. And another thing which we would like to discuss, Arjun, is what about the testis being considered as a sanctuary site?
From which sites it will, secondaries can be there. Leukemia is another thing possibility. Leukemia in ALL, leukemic deposits can be there in the test. And secondaries from the prostate being the most common site, other will be from the lungs and kidneys. They can also metastasize to the testis.
Yes, sir. So in a testicular tumor, what is the importance of doing an orchiectomy? People might ask you this question in the exam. Testis is a sanctuary site. It is a site which has got a blood testis barrier. Your chemotherapeutic agents will not go to the testis. So whether there is a burnt out disease or not a burnt out disease, it has to be removed. The other common questions which come for you in the examination is when can you start chemotherapy without doing a high inguinal orchiectomy and waiting for a biopsy?
The patient has high levels of beta HCG, or if there's high risk of hemorrhage. In those cases, immediately start 2 cycles of chemotherapy along with beta blocker. Then you do a high orchidectomy after 2 cycles.
Correct. So these are situations where the tumor is going very fast. In 1991, there was one article which was released by one Dr. Raja. He is an oncologist, medical oncologist from, I think, Apollo Hospitals, Valli Venkat. He released an article saying that there is a hurricane type of a tumor which is seen in a young boy and diagnosed it to be a choriocarcinoma. choriocarcinoma. That is where this hurricane thing started. Now hurricane tumor is so common, right? Everybody talks about a hurricane tumor. What is the classical appearance of the lung in a hurricane tumor? That's again another question that is being asked.
Cannonball mets, sir.
Why do you get cannonball mets? What do you mean by cannonball mets?
Multiple heterogeneous. Don't know, sir.
It is an uniform growth. It is an uniform growth on all directions, so that it gives the appearance of a cannon. I think all of you would have seen cannonballs. You've seen cannonballs?
Yes,
No?
yes, sir.
You heard of songs. I think Rishi has seen in his place itself. In the southern part of the country, there are a lot of cannonball festivals that go on. So like that, it's a fast-growing tumor on all directions. Any fast-growing tumor on all direction can produce a cannonball appearance. So in which case, is there any other tumor that can produce a cannonball appearance? Sometimes a CA prostate can also produce a
Yeah,
cannonball.
prostate. Yes.
The other common question that comes to you is, what is a growing teratoma syndrome? What is a growing teratoma syndrome? Yes, Venkat.
In a patient who received chemotherapy for a retroperitoneal lymph node, the mass continues to increase in size with rising tumor markers, sir, even with chemotherapy.
Arjun, satisfied?
It grows in size with the growing tumor markers, sir. And,
Rising tumor.
what are the differential diagnoses for loss of testicular sensation? One is CA testis. Is there anything else? Any other condition causes loss of testicular sensation in the testis?
Long-standing hydrocelular filariasis, sir.
No.
Calcified. Okay, sir.
Any secondaries to the testis, sir?
Mumps and syphilis.
Mumps or orchitis.
Mumps or orchitis.
Okay.
And in this patient, if the tumor markers are negative, is seminoma the only diagnosis? That's again one of the questions that is coming up. Is seminoma the only diagnosis in this patient if the tumor markers are negative, or is there any other diagnosis? Rishan?
Sometimes it might be extragonadal tumors also, in which they might present with negative tumor markers, but those are very rare, only in 5% cases.
No, this is a scenario where the testis is swollen. It
No,
is
sir,
only
it can
a
be
tumor.
it can be NSCT also, the normal tumor markers, like confirm with the hepatologist, sir.
Can it be an adult type of teratoma? That was actually the real meaning of this question. Can it be an adult type of teratoma? If it,
Yes, sir,
happens to be, if it happens to be an adult type of teratoma, what is the genetic marker for it?
Is I12P?
Correct. Come on.
I12P, sir. I12P, sir.
I12P is a marker for it. Is it aggressive or is it non-aggressive?
It's an aggressive type, sir.
It's an aggressive type of tumor.
It is when the teratoma transforms into somatic type of malignancy, sir.
Correct. Good. I think there are no more questions in the chat. Mukkani Velan has asked a question. Is biopsy needed for early or late relapse in seminoma?
Late relapse is needed, sir. Most of the late relapse are teratoma. So before starting treatment, we'll do biopsy, sir.
Okay. There is one another question that has come up by Dr. Smita Verma. Is it necessary to do an orchidectomy in case of an extragonadal germ cell tumor if the testes are normal?
Not necessary, sir.
Okay. Fine. Good. If it is an extragonadal germ cell tumor, is it a good prognosis or a bad prognosis?
Depends on the site, sir. That's mediastinal or retroperitoneal, sir. Mediastinal has poor prognosis.
Let it be mediastinal.
Poor prognosis, sir.
Poor prognosis if it is mediastinal. Good. Manohar sir and Arjun, any more things which we have to discuss?
I have two more doubts, sir. There was a question from Arjun sir which told if scrotal skin is involved, how do you manage it in high immunoorchidectomy?
Even I wanted to know, Arjun. Yes.
Sir, the thinking is you remove as much as the scrotal skin as possible because the lymphatics is varied. So then you have to remove the entire scrotal skin and plan for a patch or a graft later on. The other testis will eventually become exposed. Leave it, let it heal for some time, and then you can put a skin graft over it. So I would want to do that because the lymphatics is varied there. It is not specific.
Correct. Right, correct. And you will have to have a watch on the inguinal nodes also.
Yes.
Have a watch on the inguinal nodes also. Good. I had a small video of an high inguinal osteotomy. I just wanted to show, somehow I couldn't edit it, so couldn't show these postgraduates. And Manohar sir and Arjun sir, if you're okay, I think can we just conclude this session? I know testicular tumor is not a bigger topic to discuss, but I think we have discussed a lot of points here and exam-oriented questions. If Rishin and Venkat are happy, I think all the attendees will also be happy regarding the discussion. Venkat, is it anything you want to discuss a little more?
This
Or is
growing
okay?
teratoma syndrome answer right or wrong, sir? The definition, growing teratoma syndrome.
It's fine. It's fine only. It's
Yeah.
fine. Yeah, your answer was fine. But it was very short. That's why I thought whether Arjun wants to add a few things to that. Otherwise, it's fine.
Surgery is
Actually
the
wanted
option. Resection is
to.
the option. Resection is the option.
Resection is the option for these patients. Yes, somebody is putting up on slide. Yeah,
And this is what Changal sir put in our exam.
correct. How do you know
Uh,
this? You got it from, yes. Okay, this is one of the slides which I was asking questions how a seminoma looks like, how the other tumors look like. Good, nice. So a testicular tumor is definitely a case for your exam discussion. You will have a cut section of a testis that will be kept for you. You'll have to be, I will be asked, well, how do you identify this as a testis and what is that you are seeing inside? From there, we'll start the question, and another 10 minutes. There will be a good amount of discussion. Whatever the questions that need to be covered have been covered here. I think we should be very thankful to Dr. Arjun and Dr. Manohar. Arjun chipped in at the last moment. Ramesh sir said he was not well, he was not able to take it. Arjun came and did more than enough. Arjun, thank you very much for coming
Very
in.
kind of you to invite, sir. I thank Manohar sir also for sharing the podium.
Thank
Thank
you, sir.
No,
Thank you,
Changal
sir.
sir.
Arjun sir and Arjun sir. Thank you for being a part of this excellent session, sir.
That's really good. It's a really good discussion from both of you, sir. I think Rishan, in spite of being a second year postgraduate, kept to the pace and discussed a lot of things. And Venkat, as always,
Thank
good,
you,
we
sir.
know, is preparing for his exams. He's a very nice postgraduate. And there are, in spite of the exams, as I told you, there are still a good number of people who are attending this program. There are 90 on the other side who are attending this program. And I'm sure a lot of people will be seeing the YouTube videos also to learn a lot of things from this. So thank you very much, Dr. Arjun. Thank you very much, Dr. Manohar sir. Thank you, Venkat. Thank
Thank
you,
you.
Rishin. Thank you,
Thank you, sir.
Mankind. And thank you, Salman,
Thank you,
for
sir.
having a
Thank
very
you.
nice program. You're making it a very memorable day for all of us. So thank
Very
you very
Thank you,
much.
kind of
sir.
you, sir.
Yeah,
Thank you,
Thank
Thank
sir.
you.
you, sir.
thank you.
Thank you, sir.